Hello, everyone. My name is Mike Kelly. I'm the President and CEO of Nirvgen Pharma. Thank you for the invitation to present today. Very excited to present the chronic cohort results from our Phase 1b/2a clinical trial. Last year, when I was at the symposium, I presented all of the preclinical data and the design of this study. I'll touch on the design of the study in this presentation, but I'm going to focus on the key results that we saw in the chronic cohort. I will be making some forward-looking statements, so please look at our risk factors. We're a public company. Our risk factors are listed up on cedar.com. And so today I'm going to talk to you about the results, and then next step milestones, what we're going to be doing with these results. So I'll start off with the punchline. We hit our primary endpoint. We had a threefold increase in measuring the connectivity from the brain to the hand muscle group. I'll get into the great details of the primary endpoints and the secondary endpoints in a second, but these are the key highlights. The second big take home is that connectivity turned into function. So we actually saw a very strong trend in the GRASP score and a even stronger trend in the quantitative prehension subgroup of the GRASP score. So I'll walk you through what the GRASP score is and what the quantitative prehension subgroup is. And lastly, the drug continues to remain to be safe. This is a drug candidate that went through phase 1. We had a 75-person phase 1 study, safety study. The only adverse event we saw in that study and the only adverse events we're seeing in this study are injection site reaction. So we're excited. We hit our primary endpoint. We have a strong trend in a functional endpoint, and the drug continues to remain safe. So just to refresh your memory, this is a 16-week study, 12-week treatment period, followed up by a 4-week follow-on period to see if the drug continued to use, patients continued to improve in the follow-up period. So the study was done at a single center, Shirley Ryan Ability Lab. There are two cohorts, the chronic cohort, meaning people who've been injured between 1 and 10 years post-injury. The subacute cohort is still enrolling, and that is 20 to 90 days post-injury. And this is a motor incomplete patient population. As I mentioned earlier, there were dual primary endpoints. We measured connection between the brain and a hand muscle group and the brain and a leg muscle group. Now, when you split the endpoints, your statistical analysis has to split, so the hurdle increases pretty significantly. So to claim victory or to claim that it was a successful trial, we had to hit one or the other endpoint, but the statistical analysis plan, our p-value had to be lower than 0.025. And I could tell you that we hit the hand, and our p-value was significantly below 0.025. All of the secondary endpoints I'm going to walk you through high level, but heavily focused on the GRASP score. Demographics for the patient population. These are 10 patients in drug, 10 patients on placebo, and they were well balanced. Now, it's a small trial, but the balance of these populations, this is a pretty impaired population with cervical injuries that had limited use of their hands and their legs. And this is the money slide. The left-hand graph on this slide shows you MEP amplitudes, which is motor evoked potential amplitude. It's the strength of the signal going down the corticospinal pathway to a sensor on the hand. You see separation early on and continued separation and a threefold improvement in the signal that's going from the brain to the sensor. The secondary endpoint is GRASP. As I mentioned, the top half of this slide is the GRASP score, looking at all of the different subgroups. And you can see that we had a significant trend in the overall GRASP score, but the bottom of this slide highlights quantitative prehension. Quantitative prehension is a functional scoring system of the hand. It measures movement of the hand, and it's a performance-based score, so it also measures time. And you can see that we had a 3.7 versus a 0.4. The drug-treated group had 3.7. The placebo group scored a 0.4. So it was and the p-value was 0.0447 in this. So this gave us clarity that not only can we make the connections, or NVG-291 can make the connections, but NVG-291, those connections can actually turn into functional improvement. Now, this is a take-home of all of the patients that were in the GRASP score, actually the quantitative apprehension score. If you look at the blue bars on the left, this is the treated group, and the red bars on the right, that's the placebo group. So these are all patients. Every single bar represents a patient, and it shows you that 7 out of 10 who received NVG-291 had an improvement, versus 4 out of 10 in the placebo group had an improvement. And not only did more patients improve, but the magnitude of that improvement is significant. Now, I asked one of our advisors, apprehension, is this clinically meaningful? And the answer that I got was, if somebody experiences a 3-point improvement on one side of their body, that's the difference between them being able to look at a bottle of water on the table versus picking up that bottle of water and bringing it to their mouth and taking a sip of that water consistently over time. So you can see the magnitude of shift of what we saw in the study, and obviously it is clinically meaningful. So let me explain a little bit further what quantitative apprehension scoring is. It's a 4-part scoring system that looks at pouring water into a glass, taking pegs out of a foam board, picking up a key off of a flat surface and being able to turn it, and then picking up a nut and putting it on a bolt and being able to screw it on. So these are actual measurements of function of people who have been impaired. So when you can improve function, in addition to improving signaling, we now believe we have a regulatory path that we can sit down and talk to the FDA about these results. When we looked at all of the other secondary endpoints, we did not reach statistical significance, but there's a couple of learnings that I'd like to share with you. The 9-hole peg test as an example. Not all participants in the study could finish the 9-hole peg test. In fact, roughly 50% of them couldn't finish the test at the beginning or the end of the study. And when that happens, you get the maximum score of 300 seconds because this is a timed test. So when you have half the population that cannot finish the test and they max out their score, your statistics are shot. The 10-meter walk test, we had 2 subjects in the NVG-291 group that couldn't complete the walk test in the beginning of the study, but could complete it at the end. And we also had a pretty significant outlier in the placebo group who had an extraordinary result, which is we're digging into to try to explain. The pinch force and the upper and lower extremity motor scores, there was no difference. But we didn't expect to see much in the upper and lower extremities motor scores because they're actually very generalized scores, unlike the quantitative apprehension score. And then lastly, the drug is very safe. You can see here, these are the treatment emergent adverse events. The most common was injection site reactions. The injection site reactions were modest and minor, and there were no treatment discontinuations. So to summarize, we hit our primary endpoint. We have a strong trend in a functional secondary endpoint, and the drug continues to maintain a safe profile. So we fully believe that we now have the ability to sit down with the FDA, discuss these results, and map out our regulatory path moving forward. Just a reminder of the size of this market. This is a massive market with no current treatment available to help these folks. Once a patient gets to 9 to 12 months and they plateau in their recovery, that's where they are. And the cost of illness in this population is pretty tremendous. So if you look at the patient population, there's 300,000 people living with spinal cord injury in the United States. There's roughly 165,000 with cervical injury. And then we looked at the motor incomplete population, which is about 125,000. So we believe that this is still a significant market opportunity. So where to from here? Our next steps are to meet with the FDA and get some feedback and talk about what pathway we're going to go down towards approval. We're going to continue enrolling in the subacute cohort. We're not going to wait for the subacute cohort to finish. We're meeting with the FDA with the chronic cohort results because they're so exciting. We will continue to enroll the subacute, and that will become a confirmatory trial. And then we're going to continue to expand our pipeline as we grow as a company. Thank you very much for your time today.